Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in optometry. Discover a new show at itube.net/podcasts.
You're listening to The Mod Pod, a companion podcast to Modern Optometry, the go-to publication for full-scope ODs navigating the evolution of our profession. I'm your host, Cecelia Koetting. Join me every month to hear me speak with authors from each issue. We'll talk about their articles, get more in depth about particular points of interest, discuss how to apply tips and suggestions in real-life practice, and more. Hi, everybody. It's Cecelia Koetting coming to you from Denver, Colorado. I want to welcome you back to this month's episode of the Mod Pod. Tonight, we have Kaeleen Franson, who is an optometrist in Salt Lake City, Utah, practicing at Broadway Eye Clinic. She's here to talk to us today about her article, Early Treatment in Myopia Management, the Key to Best Success, that is in this month's Modern Optometry. Welcome. It's great to have you on the Mod Pod.
Thank you so much for having me. I'm excited to be here.
Absolutely. So would you mind giving us, myself and the audience, a little bit of background on who you are and a bit about your practice? And what's your Starbucks order?
Yeah, so I practice at Broadway Eye Clinic. We're in the heart of downtown Salt Lake City. I have been there for about 8 years, and we have 4 amazing all-female doctors there. And we thankfully get to do just a little bit of specialty here and there, whatever we're interested in. So we have specialty contacts, neurooptometry. I'm really big into ocular surface disease and dry eye. And then we've always dabbled in myopia management throughout those years. And really in the late teens, when literature started coming out a little bit more with myopia management, and then with the launch of the FDA-approved MiSight lens, we really just went all in on myopia management. And now we're up to treating hundreds of kids in the Salt Lake City area. And it's something that I'm really proud to be part of. So
that's so awesome. That is something that is really proud to be, something that is to be proud of, right? That's a really commendable thing. You're helping kiddos. What is your Starbucks order?
Oh, that's right. Yeah. So I'm actually more of just the brew coffee at home and take it on the go. But when I do hit up the coffee shops, I like more of their specialty lattes, and like the seasonal lattes.
Yeah.
So
whatever the fun one is of the moment.
Exactly. Got to try something new.
So one more question before we move on and kind of dive into this. Will I see you at Mod Live in September?
Unfortunately, no. I got some other commitments in September and just trying to balance life and family and all that fun stuff. So
absolutely. I understand. But there's always still time to register if things change, or even next year. And Nashville is such a great city. I am, one of the faculty. Maybe in the years to come, you can come join us and have a great conversation. It's always a really fun kind of modality of a conference. It's a lot more conversational. It's a lot more kind of collaboration between optometry and ophthalmology, which is pretty cool. So think about it in the future. Yeah. Absolutely.
Yeah, that sounds amazing.
So I will be the first to admit that because of my specialty area, and we can't wear all hats, right? I don't honestly know a lot about myopia management. I've read through the articles. I've sat down and talked with people like you who really kind of give me the what's what, so that I at least can appreciate it, right? And I do know that arguably it's already at pandemic levels. Can you help set the stage for how big this problem truly is?
Yeah, certainly. So when we're looking at the global population, we are already at about 1/3 of the population being myopic. We've probably all seen those studies that by 2050, 50% of the population will be myopic. And again, that's globally. When you're looking at communities like those in East Asia, those are actually going to be pushing 80-90% by 2050. So it's a huge problem. I think then you have to further think about 1 in 10 of those myopic patients are going to be high myopes, meaning above a -5. And we all know when you get those higher prescriptions, you're going to be more at risk for retinal detachments, glaucoma, etc. So I think when you look off into the future, then we're going to have a really big problem on our hands with how much disease we're going to have to manage, and we might not have those resources, right? I think another way to look at it is most of us in private practice or in general practice are really educated in diabetes, and we talk about the prevalence of diabetes. Well, that's 10% of the US population. Myopia is 30, right? So I know those aren't exact comparisons, but again, when you have a child in your chair that has a 1 in 10 chance of developing those diseases later on, I think that's something to really consider and start to embrace myopia management from that aspect.
Yeah, absolutely. I know you say the future, but 2050 is really not that far. That's 25 years, not a little over 25 years from now, right? And if we think
That's
about,
true. Yeah.
right? I know, I'm
Feel
like,
old.
man, that's not that far. And that's really concerning. And your article is really focusing on the when of treatment, which generally across the board, earlier is better. I mean, you brought up diabetes, right? So obviously the earlier intervention, the better. The earlier we have discussions about the concerns with it, the better. Who are those that we should be treating, and how do we identify them?
Yeah, so like you said, earlier is better, right? We know that there's this dramatic growth period from when a child is 8 to 12. That's when most kids are getting their first pair of glasses. You're seeing these big jumps in the prescription during that time. So I think it's really great if we can start having those conversations before that period, 5, 6, 7 years old. And it can start as simple as just talking about the risk factors associated with myopia. And then how to identify them, you can just look at those risk factors. Are their parents myopic? What's their ethnicity? How much indoor time and screen time are they doing versus outdoor time? And have those conversations. You can also look at the age expected norms of where their hyperopia is. Are they less than that age
I
expected
even
norm?
remember those, yes.
Right? Yeah. So you can look at those and say, okay, you're below that. So I think you're going to dip into myopia a little bit more. You can start measuring axial lengths. We have a variety of options available to us to find those patients.
So who would you say of those, let's go back to the age expected norms for where they're at, right? Um, when might you actually pull the trigger and start treating some of those patients based on that? And I know that's not the only thing you're looking at, but
Right. Again, I think you have to add that into their risk profile, right? So if their parents are myopic, their eye with the axial length measurements are growing too long, too quickly, I would pull the trigger a lot sooner, maybe even starting in the +50, +1/4 range, depending on what the parents want to do.
so say this person has a few risk factors, right? Family, we're concerned about axial length, we're noticing that they're where their refractive error is a little higher or lower than we would technically expect, right? That's putting them at a higher risk. How often would you suggest watching that kind of pre-myopic patient? And what do you suggest we use to really monitor that patient?
Yeah, so when I have a higher risk child, I might watch them every 6 months for a while and see how that goes. Certainly, I might just still be monitoring them annually, depending. I'm always going to be starting that conversation with the parent and the patient on, hey, this is happening. We need to be paying attention to this so that we can on it as soon as it's necessary or when you're ready. So I have, again, patients who are slightly hyperopic, plano, that I have in treatment currently because their parent is a -9, right?
Right. You
So,
see the writing on the wall. You know what's coming.
yes,
Yeah.
exactly. Yep.
So when you say you're watching them, I know you mentioned axial length is one of the things.
Yeah, so that's one of our main components at our office is we have a biometer. We're measuring that, yeah, axial length. Just like we have those hyperopic norms for children, we also have where their eye should be at what age and how quickly we expect that growth to occur. So again, if they're outside of that curve, we're going to want to start treating them probably a little bit sooner.
So say it's a a doctor, right, one of our colleagues who doesn't have the access to axial length, do they kind of just go based off of some of the other things, the risk factors that you were talking about, and then maybe refer laterally to you?
Yeah, so you definitely do not need a biometer to get started in myopia management. Again, you have the tools and access to the manifest refraction, the history of that child, and you can make a good decision just based solely on that. If you want a little additional help, yeah, I certainly always encourage you to find another office nearby that can measure that axial length for you and just send those results over.
Yeah, it's a good opportunity for us to co-manage within optometry, right?
Right. Yep.
I'm always for co-management, whether it be between or to ophthalmology. I think it's relying on a friend is a good
Yes,
idea.
exactly.
Yeah.
I think of it like your OCT, right? You might not have an OCT, but you can still help identify and treat macular degeneration.
Yeah, absolutely. When we do decide to treat these pre-myopic patients, the ones we're talking about that are at that risk where you're like, no, we're going to do something. What do you actually find are the best methods in some of these earlier patients that we have available right now?
Yeah. So again, I preach lifestyle changes and all of those things first and foremost. I think that also really sets the stage in the future when you're wanting to pull the trigger on an actual treatment. And so the three main ones that we have in the US currently are the soft multifocal contact lenses. You can use off-label, multifocal lenses off-label as long as they're distance centered. We have that FDA-approved MiSight lens. Johnson & Johnson's coming out with the lens shortly, so we have those options. In my practice, we still use atropine quite a bit, even though the evidence is a little shaky nowadays. But it's a great option for those that aren't quite ready for contacts. And then we also utilize a lot of ortho-K lenses, depending on corneal parameters. It's a great option to get a child in myopia management and not having to wear glasses and contacts throughout the day. I'm very much looking forward to the glasses being available in the US as well. I think that's really going to open up how many kids we can treat for myopia management.
Yeah, I've been hearing really good things about the research that's coming from that, and a lot of my myopia management friends are very excited, just like you. So it's a good
Yes.
thing.
Yep. I have a couple of
Now,
patients that have gone to Canada for them. So
yeah, which is not the easiest, but
no,
um,
they're committed.
so
I love them.
when you already mentioned this, talking to the parents right early about some of the things where you just kind of setting the stage so that they know what to expect. And of course, with anything, parents can always be a big hurdle, especially in some of these probably earlier pre-myopia patients, where it's not like they're like, we're there, right? It's like, we're gonna get there. Do you have any pearls for our colleagues in how to have this discussion and really get the patient's parents on board with what's going on in treatment?
Yeah, I mean, I think that those early discussions are crucial because you're already kind of prepping that parent and that patient that this is coming, right? So then they accept that treatment a little bit better. But when you do have that -1 that's already in your chair, and this is the first time that you've seen them, I will start to talk a little bit more about those risk factors in terms of the ocular health. At a -1, we're already starting to see a 4 times risk for glaucoma, 3 times risk for retinal detachments, and it's only going to go up the higher amounts, right? So that's really powerful. I'm a parent myself. I want my child to live the healthiest life possible. So if I can prevent some of that stuff from occurring, of course I'm going to do it. So I think that's really powerful. And another big takeaway is trying to tie in something from that child's life back to what we're trying to do. So if they like to play the piano or are in gymnastics, I like to kind of try to paint a picture of we can treat that child's nearsightedness now and prevent it from getting worse so that when they're out doing whatever activity that they're doing, they're going to thrive in that. Again, us parents love to think about the children that we're going to, or how our children are going to grow and who they're going to grow into. And we just want the best for them, right? And so really tying that back in and hitting home, hey, I'm part of your child's life. I want the best for them too. This is the best thing to do for your child. I think just coming from a place of sincerity with that goes a really long way.
Yeah. And that's, very similar to how we have other conversations with them about other issues. So where were you guys when I was a kid? I was a -6 before I had LASIK, and it got even worse during optometry school. Oh man.
Dang it. Yeah.
Right? I know.
Yeah.
If only, if only. So finally, I'd love to ask, what 3 words or less would you use to describe optometry today in 2024?
I'm very usually long-winded, so I don't know if I have 3 words, but I'll just say, I think in 10, 15 years from now, myopia management is going to be the standard of care. We have a great opportunity to change children's lives and future generations, and I would just encourage all of our colleagues to embrace that.
I love it. For those who want to know more and hear more from you, where can they find you on social media?
Yep, so I'm on LinkedIn, Instagram, just under my name, Kaeleen Franson, and then you can always email me at kaeleenfranson@gmail.com.
Well, Kaeleen Franson, thank you so much for being on the Mod Pod. It was a pleasure. I learned a lot, and I'm sure our audience did as well. And everybody stay tuned. Join us after the break for a chat with Marc Bloomenstein.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in optometry. Discover a new show at itube.net/podcasts.
Hey everybody, it's Cecelia Koetting. Welcome back to the Mod Pod. I'm coming to you back again from Denver, Colorado. And tonight I've got our friend Marc Bloomenstein, who is at Schwartz Laser Eye Center in Scottsdale, Arizona. And he's here talking about his article this month in Modern Optometry, Curing One Problem While Creating Another, Glaucoma Management and Ocular Surface Disease. Welcome, Marc. It's great to have you.
Cecelia, it is a pleasure. Thanks for having me on the podcast.
Absolutely. So I think most of our friends listening, if not all, know who you are. You've been a rock star in optometry for, a couple decades, right? And we know that you're not just a David Cross lookalike. Yes, I was going to throw that in there. But humor me. Would you mind giving us a little background on who you are and maybe a little bit about your practice? And what's your Starbucks order?
Oh, God, these are great questions. And thank you for the David Cross reference. One sexy mofo. So I'm going to say, Google that, people. Google that. So yeah, Marc Bloomenstein, I literally just had my 30-year optometry anniversary. I graduated optometry school 30 years ago, 1994. And I pretty much have just worked in cataract refractive surgery, med-surg, seeing patients here in Arizona. My whole career. I've been fortunate enough to be involved as a KOL in a lot of different companies and get excited about seeing new products and seeing what's in the future. I've also been a pretty active participant in some clinical studies over the last couple decades. I've been a PI in I think 23 studies.
Wow.
Yeah, we're doing a few right now. And I bring that up, Cece. Is it okay if I call you Cece, or are we going with Dr. Koetting?
You only you.
Okay, thanks. See, is because I think part of our profession, what makes us fantastic, is that we move quicker, I think, than the OMDs, and adopting new ideas and integrating them into our practices and helping our patients. And so, being on the forefront of what's coming enables us to be able to talk to patients about, hey, come back in 6 months or in a year. We're going to have something exciting to help you with that. So it's always been really, really gratifying for me. I don't know what else you want to say. I mean, I'm the CE chairman for Vision Expo. Yeah, I'm the dad of a first year optometric student. I tried to talk him out of it, but yeah. But no.
Well, you failed, and now he's gonna follow your footsteps. I mean, it's not bad.
No, he's doing great. So I look forward to that.
That's pretty exciting. Okay, but what's your Starbucks order? I heard you ride your bike every morning to Starbucks with your wife.
100%. No, she stopped riding with me. Oh my
Oh no,
God.
what did you
Yeah.
do?
So I don't know if we can cut that out, but the problem is that I had to start going earlier and earlier. So, we got to be at the office by 8, and they moved the Starbucks. So it's about a 10-mile round trip.
Oh wow.
So yeah, it takes me about 45 minutes to an hour to go there and back. And she's like, too early, bye. So now she gets coffee in bed. I'm hardcore Pike Place. Just throw a little milk in there and some sugar. I'm living my best life. But I will be honest with you, Cecelia. I drink probably about 40 to 60 ounces of it a day. Yeah.
That's a fair
Pretty-
amount.
Yeah, pretty wired.
Today is brought to you by caffeine.
Yes, it
Absolutely.
is.
Yes.
Yes.
So one more question before we move on. Will I see you at Mod Live in September?
I am not going to be able to make it to Mod Live in September.
That's okay.
But
I know you're busy.
yeah, but I think I might see you though. Is it interactive? Is it going to be online at all or no?
I don't believe there's an online component this year, but it may be hybrid. I'm not 100% sure. But it is a fun meeting. So even if not this year, you definitely should think about it in the future when you find a little extra time, or maybe we need to just bring you in as a faculty.
I have been there. I mean, it is really the thing that's phenomenal about that meeting. It's very interactive.
It is.
And very practical, and
it's both optometry and ophthalmology interactive, right? And that's what I love. The panels are all of us up there just talking like eye geeks, which is fun.
Yeah, I like it. I like it.
So your article actually focuses on glaucoma and ocular surface disease, and how often in treating one problem, we actually a lot of times are creating another. There are those of our colleagues who may argue that dry eye isn't that bad and treating the glaucoma is actually more important. I argue that both are. What are your thoughts?
So I straddle the fence with the reality of this, is that I don't necessarily think we do a great job defining dry eye to our patients. And what I mean by that is that I think that oftentimes the diagnosis of dry eye is almost the end game of the disease state. It's when the desiccation of the epithelial tissue is at such a place where it's affecting vision significantly, or patients have significant foreign body sensation, or it's brought to the forefront. And this is, ocular surface disease is a chronic disease. It starts and then progressively gets worse. The interesting thing is that glaucoma is also a chronic disease that starts and progressively gets worse. When we're managing glaucoma, our goal here is to preserve vision. We want to preserve the optic nerve. We want to make sure that patients have a full field, and it's easier to sit there and look at a patient and say, we have to do this because we want to maintain your vision. And I think we sometimes, no pun intended, lose sight of the fact that if we don't have a good ocular surface, then it doesn't really matter what's going on in the retina or what's going on behind the eye. So what I usually say to my colleagues who sit there and say, you know what, I don't care about the ocular surface because lowering the pressure or getting the pressure to a place where it's sustainable for this person's optic nerve is more important. I remind them that at the end of the day, our goal is to give our patients the best quality of life and to give them the best quality of vision. And so we have to figure out a way to marry those two, and also provide our patients with the ability to sustain one condition by not, making another condition worse.
Yeah, absolutely. Because they're both important. Who's it? Steve Ferrucci, who says that the only thing that matters essentially is the back of the eye.
Yeah, I know.
Right,
but
right.
yeah.
But he even he'll admit now, I think, that it does matter. It's like looking through a dirty windshield. If that windshield breaks or isn't there or starts having severe issues, it's going to make it very hard for anything to be mattering in the back of the eye. Yeah,
100%. But but Cecelia, I want to also argue this though, is that when an OD or an MD makes the diagnosis of glaucoma, and you have that discussion with the patient, you sit down and you basically say, look, these are my findings. These are what I'm seeing. And because of my clinical acumen, this is how I want, to manage it. Patients, there's a trust that basically that happens between you and the patient. To me, ocular surface disease is the exact same discussion. I am seeing things. I realize, the things that you're doing in your life. And if I don't manage it or do something about it now, then we're going to have problems in the future. And so I really believe that when you're managing glaucoma, you're also having the same mindset of managing ocular surface disease. We just have to marry those two thoughts.
Yeah, no, absolutely. And so in marrying that, and when you have these patients, where do you find yourself going as far as to kind of to bring these two together? Do you find yourself changing the glaucoma medication, or do you find yourself starting on ocular surface disease treatments and leaving the medication alone for the time being? What do you do?
It's interesting because there's no, I think everybody always wants kind of like this kind of easy button, especially when we're kind of like managing conditions, and everybody is so different. But I always start from the perspective of less is better. And so what I mean by that, especially, is that when you start looking at, when you have a patient who has glaucoma, to me, what is the strongest medication I can give with the least amount of maybe BAK, or the least amount of, preservative period or effect on the patient's ocular surface. But I'm also Johnny on the spot to look at other factors, that might contribute to exacerbating the dry eye. For example, are they diabetic? Do they work on a computer for a long period of time? Do they have, any autoimmune disorders, or anything that to me is going to, contribute to that. So I'm really more kind of looking at where they starting, where they ending. So if they, to your point though, Cecelia, if they have ocular surface disease, then my thought is, what can I do to not exacerbate that? If they don't, if I haven't started managing ocular surface disease, I'm going to look at the glaucoma medications that are going to be the best, and then see how I can tailor those.
Yeah. And one of the nice things is that with preservative-free glaucoma medications in the last couple of years, we've gotten a lot more options.
Oh, and MIGS, and we've got MIGS, SLT, yep. We've got, I think sometimes we get blinders on and just think, oh, we've got a great drop. But, there's been enough studies to show that patients who are on an average of 1.9 or a little bit more than 2 drops are the ones that have more significant ocular surface disease.
Yeah, absolutely. Because it also, the patient's compliance goes down the more that they're taking too, right? And so we know that if we can get them off some of those medications, not only are we potentially helping their ocular surface disease by putting them, doing a MIGS, SLT, but we also may be helping their glaucoma and getting them better under control.
Yeah. So it's interesting you say that. I have a love-hate with the word compliance, because I feel, and it's funny, is if you read my article, you'll hear my voice in my article. I like the word adherence. I don't necessarily feel that patients aren't compliant. It's not that they're like, no, screw you, Dr. Koetting, I'm not going to do it.
It's kind of a negative word.
It is. Yeah. And adherence is, look, make it so that it's easier for me to be able to do what I need to do. And I think that if they're getting burning, light sensitivity, if they're getting sequelae from the drops, they're going to be less adherent. So things that we can do to make it more comfortable, things that we can make it do to not change the quality of their vision, then they're going to be a lot more adherent to medications, and especially in the glaucoma realm.
Yeah, absolutely. So as we're coming to our end here, because it's quickly gone, do you have any other thoughts on taking care of our glaucoma patients that you didn't have room for in your article that you would like to discuss?
I think that the one thing that I really always want is be a compassionate doctor. One of the things that I always think is that it's interesting to me, because I always look at a patient in my chair and I think, I'm glad you came to see me today, because I'm going to do something that maybe another doctor hasn't done for you. And what I mean by that is look for ways to make it easier for patients, and think of how you can meet the patient's needs in everything we do. And sometimes it might just be easy to say, oh, I'm going to write you a drop, but patients are terrible with drops. So we got to think outside and do something a little bit differently.
So I'd love to ask what your message or wisdom you would like to impart on our colleagues, not necessarily about the topic that we're discussing today, but essentially maybe what soapbox do you have this week?
So it's an interesting question. And I had a patient a long time ago who was a salesman, and he went into a meeting and he wrote MYD. And he was training this group of people. And he said 5 days went by. Nobody asked him what MYD was until the last day. And I looked at him and I said, MYD. And it said, make yourself. And I was trying to think what the D was. And he said, make yourself different.
Yeah.
And I thought to myself, I feel as optometrists, we should make yourself better. And to me, I've kind of go by the MYB is that look for things that are new, that are different, that are going to make you a better doctor and help your patients to get better. So I'm going to leave it with MYB, make yourself better.
I like that. For those who want to know more and hear more from you, where can they find you on your social media?
I do. Well, I'm really not on social media, but I do have, I know, I have
I've
no
looked,
footprint.
I'm like, why doesn't Marc want to be my friend? And it's like, oh, you're just not there. Okay.
I accidentally logged into LinkedIn once using my Gmail, and I'm like, no. And then I just got like emails. I'm like, no. I'm not even on my Peloton. I don't even have friends. But I do not a podcast, a webcast, collaborative corner, so they could go, through the what is it? iTube OD, I think it is.
Believe it is iTube OD. Yeah.
Good. Yeah. So there you go.
I've seen that.
Or they could just play this, close their eyes, and just visualize what we look like, and that's how they can see us.
So thank you so much for joining me. I really appreciate having you on the show. And thank you to the audience again for joining us and listening to this month's The Mod Pod. And don't forget, Mod Live Nashville is this September. Be there. Go to modlivemeeting.com for more information and to register. And I hope to see you all there.